Let's continue with perfusion problems. This time, we'll focus on coronary artery disease. Now, risk factors for this are not any different from what you've learned before for hypertension, diabetes. They share exactly the same risk factors. So CAD is by definition, this is the accumulation of fat deposits in one or more coronary arteries. So therefore, if you have coronary artery disease, what is the underlying or the predisposing risk factor? What did you have also? You have atherosclerosis, right? Okay.
What did you guys say?
726. So atherosclerosis is the root cause here. And to think about it, is atherosclerosis only going to grow in the coronary arteries? Okay, so if the coronary arteries are affected, that means all other arteries are also affected. That's why they share the same risk factors with other chronic conditions like heart failure, diabetes, hypertension. They have exactly the same in stroke also, because stroke is simply a cerebral artery, but it's the same atherosclerotic disease. Okay, affecting, just depends on which artery we are talking about. So this is again the accumulation of lipid fatty substances in the fibrous tissue of the artery. So this is the root cause of coronary artery disease. How did it grow? Well, you have the risk factors. I won't test you on the actual pathophysiology, but let's look at this illustration. So this is a normal artery. These are the parts or the layers of your artery. So we have the endothelial layer, intima, media, and adventitia. Please observe where the plaque actually grows. It's not on the endothelium, but rather underneath. So the growth here, look at the endothelium. It's raised, right? It was raised and lifted off of the intima. So therefore, when you raise it like that by growing this atherosclerotic plaque, that means it weakens the endothelium, predisposing it to rupture. Because what will happen to blood pressure when you add an atherosclerotic plaque? Okay, because what happens to the lumen or the size of your artery? Okay, so that increases vascular resistance, right? So therefore, it raises afterload, increases blood pressure, and then because your endothelium is now weak, it will rupture if you add high blood pressure there. And then once ruptured, then of course that triggers the clotting cascade, correct? So once one or more portions of your endothelium breaks or ruptures, then of course platelets gather there. You have a blood clot, you get a heart attack. Okay. So these are the various coronary arteries. So you have the anterior and the posterior view. Take note that the coronary arteries arise from the base of the aorta. So it's not really going to perfuse the coronary arteries during systole. So the heart muscles have to wait until during diastole before they receive blood and oxygen. The ventricles have to relax before coronary sinuses fill with blood. Manifestations of coronary artery disease would, of course, be related to myocardial ischemia. So if, again, one or more of your coronary arteries have these atherosclerotic plaques, depending on how many percentage they are obstructed or narrowed, will determine the severity of your manifestations. Early on in the disease, the patient will be diagnosed with angina pectoris. Now, angina pectoris is not an acute coronary syndrome. So we'll talk about the 3 acute coronary syndromes later. So this is the chronic manifestation of CAD. So early on in the disease, the patient will be complaining of chest pain brought about by ischemia. Now the chest pain comes on usually triggered by increased myocardial oxygen demand. So any activity that increases your heart rate, because what will happen to myocardial oxygen consumption and demand when your heart rate increases? It increases, right? So therefore, there's an imbalance between oxygen supply and demand because the arteries are narrowed. So as the arteries narrow and you have an increased oxygen demand, do you have enough blood flow to supply the increased oxygen consumption? No. So therefore, ischemia results and it's manifested by chest pain. Okay. So again, in angina pectoris, there is a precipitating event. Now, does it have to be a physical exertion to increase your heart rate? What other activities do you do or conditions raise your heart rate? Anxiety. Could it also be joy? Say you won the lottery, 1.2 billion. What will happen to your heart rate? And you could have a heart attack, right? Okay, and then die, and then don't worry, your family will claim the 1.2 billion. Okay. Or whoever finds the ticket when you drop dead. Okay. As already mentioned, risk factors the same. If you remember metabolic syndrome, that's part of the risk factors. So metabolic syndrome again is high lipids, hypertension, pre-diabetes or diabetes, and then abdominal obesity, right? 40-inch circumference for men, or 35-inch circumference waist circumference for females. So here's metabolic syndrome. So those are the four. So if you have one or more of those, you have metabolic syndrome. Here's the complete risk factors, chart 23-1. So for CAD, you have modifiable and non-modifiable risk factors from age to ethnicity or race, gender. Now, of course, primary hypercholesterolemia is included here because cholesterol is not only developed because of your diet. It's not only influenced by your diet, also from genetics. Say for my family, for instance, all of us have high cholesterol in my family. Whether or not I have a brother who's vegetarian, he still has sky high cholesterol, right? So no matter what he does, it's just how we are. Okay, so my father died after multiple strokes and multiple heart attacks. And I have diabetes on my mother's side. So it's a fun, it's a fun family tradition. Okay. And these are your modifiable risk factors: smoking, diabetes, hypertension. Why are they modifiable? They can be treated, they can be prevented or modified. All right. And of course, prevention would be, which one can you prevent? The modifiable or non-modifiable? Okay, so you modify the modifiable risk factors, and then that will help prevent CAD. So these three conditions here, type 2 diabetes, hypertension, and CAD, share the same risk factors. So if you have metabolic syndrome and the other risk factors on chart 23-1, then you're a winner. Okay, so you can have diabetes, hypertension, and coronary artery disease. Okay. All right, so I won't bore you with the prevention. So that's self-explanatory. Let's go now to drugs to lower cholesterol. Table 23-1. The most cardioprotective medication class are the statins. Of course, they have quite serious side effects, ranging from muscle pain to liver failure or liver damage. But nothing really beats the statins. So we have non-statins, we have fibrates, fenofibrate, gemfibrozil. These are the non-statin options. Or you have bile acid sequestrants, meaning they prevent the absorption of lipids in the GI tract. Therefore, side effects of these would be what? Because now you can't absorb fat, or it decreases fat absorption. So can it cause diarrhea? Okay. And then we have ezetimibe. Sometimes they can be combined with statins at the same time. So we have combination drugs. Frankly, I've never seen patients admitted in the hospital with these two. So I'll just test you on the first four groups: statins, fibrates, bile acid sequestrants, and ezetimibe. All right.
Professor,
Thank you.
is
It's
that
only one.
the same medication we use for blood pressure?
No, this is only for cholesterol, to lower cholesterol. Since again, atherosclerosis is the root cause of coronary artery disease, so this would be vital in the treatment. So therefore, stroke patients, heart attack patients, PAD patients, peripheral artery disease patients, all take statins. Okay. So when we go to stroke for exam 2, we'll talk about these again. Okay. Okay, so here's angina pectoris. Again, the root cause is atherosclerosis. Now, this patient obviously has a certain percentage of narrowing in one or more coronary arteries. The nature here again is an imbalance in oxygen supply and demand whenever the patient has increased heart rate. So there's always a precipitating event here. Unlike acute coronary syndromes that are not precipitated by anything, meaning there is no trigger in the chest pain in acute coronary syndromes. In angina pectoris, it's always preceded by an event that raises the heart rate. So it could be shoveling snow, it could be sexual intercourse, or it could even be foreplay. Okay, it could also be joy, excitement, okay, some severe emotional event, okay, whether it's pleasant or unpleasant, that if it increases your heart rate, then it can lead to chest pain. However, the good thing about angina pectoris is it responds to rest and nitroglycerin. Sometimes rest alone is enough, but more often, if the patient is diagnosed with angina already, then they need NR prescribed nitroglycerin. So they carry these tablets or sprays with them everywhere they go. Okay, so these are some of the triggers. So physical exertion, even eating a heavy meal, okay, because that is, of course, going to increase oxygen demand, not necessarily increasing the heart rate, but it increases oxygen consumption by the GI tract. So therefore, it shifts during parasympathetic activation. When you're digesting, of course, blood is shunted away from the heart, correct? Blood goes to the GI tract. So it still leads to decreased oxygen supply. So there, shunting of blood for digestion. That's enough to trigger the symptoms. I won't test you on chart 23-2 because chest pain is chest pain. Plus, for these, it's really for the providers, for the doctors, not for nurses. Again, so any emotional event, it could be pleasant or unpleasant, still affects heart rate and therefore causes symptoms. Now, the manifestations in angina is almost only chest pain. However, there can be associated signs and symptoms. The pain may radiate to these parts of the body and associated also with these sensations. In females, that's why mortality is high in females. they do not present with the classic manifestations found in males. So the number one killer in women really is cardiovascular disease, okay, because of this atypical presentation that is seen in women. Here are more manifestations. Now, the classic ones you see here are really because what will happen to cardiac output when there is myocardial ischemia? It drops, right? So automatically, what will be the reflex response by the body? Release of epinephrine. So when epinephrine is released, of course, that will manifest in increased heart rate, the diaphoresis, okay, and then of course dizziness, and then the cold, clammy skin. Right, so here the pallor, shortness of breath, these are all manifestations of sympathetic stimulation. Now, why is the GI tract involved? Why is there nausea, vomiting? Again, there's vasoconstriction, correct? So blood is shunted away from the periphery. All blood is going toward the heart, lungs, and the brain only. We'll talk about unstable angina when we get to acute coronary syndromes. Now, here again, the management is nitroglycerin. Once the patient is diagnosed, then they will be prescribed nitroglycerin for them to take as needed. They can even take it preemptively. So let's say they learn over time that, oh, last time I had sex with my wife, I had chest pain, I couldn't finish. So what will they tend to do? Take the nitroglycerin for the activity, and then all is well. Okay. Now the PCI here, which is percutaneous coronary intervention or cardiac catheterization, can be done as a diagnostic as well as a preventative intervention, meaning they can use PCI to diagnose. Okay, so a PCI uses a dye, so you'll be taken to the cath lab. They'll thread the catheter in we use the radial artery now. Unless it's not available, then we'll go through your femoral, but we use the radial artery now. So we'll thread the catheter and then inject the dye into the coronary circulation, and then it will help the doctor see where are the blockages. So that is diagnostic, correct? However, while they're there already, if there is significant blockage, then they'll go ahead and put a stent, okay, to increase the opening. So this is a option for management. Okay, so the patient didn't actually have a heart attack, not yet. But again, while they're there during the diagnostic procedure, why not just put the stent if it's applicable, if appropriate? So we'll look at the table later, but since we have the paragraphs first, okay, so a few facts we need to know about nitroglycerin. Nitro has several forms. So for emergencies, we have the short-acting forms, which are the sublingual tablets. So you've seen Carl Shapiro's chart, right? He had what, 0.4 milligram of what was it, sublingual tablets? Okay. So the dosing is 1 tablet every 5 minutes because it's a short-acting form of nitroglycerin. So it helps dilate arteries. Although it's supposed to dilate only the coronary arteries, however, it does have systemic effects. So it can cause generalized vasodilation also, including blood vessels in the brain. So what is a common side effect of, which is manifested by what? Okay, the patient will complain of a headache when they take nitroglycerin. Now, because of that, of course, can you give Tylenol? Why not? Yes, you can give Tylenol, okay, knowing that, especially when the patient complains already, I'm having, the chest pain is gone, but I'm having a splitting headache. So you can even preemptively give Tylenol, okay, if ordered. So we have the sublingual tablet or spray, or it can be oral capsule as well for maintenance. It can also come in a topical agent. Now, take note that when it's a topical agent, since this is in the form of an ointment, and we apply it on a hairy part of the body, and of course you wear gloves, right, when administering any ointments, they are only supposed to be on for 12 hours. You take them off after 12 hours. The reason is they develop tolerance to nitroglycerin,
That's including the patch and the.
patch or ointment. So they have to be removed after 12 hours. So on your MAR, on Epic, let's say the order is 9 a.m. or 10 a.m. So it will appear on your MAR 10 a.m. It will say apply. By 2200, which is the next shift, it will say it still appear on your MAR, but instead of administer or apply, it will say remove. Okay. And also, if let's say your facility doesn't use Epic, so then therefore no robust clinical support like the example I gave you, please make sure to take off, because when you're administering a patch or an ointment, that means there was one administered before, right? So therefore, look for the old one first, take it off, and then apply a new one. Okay?
So-
One time I've seen a patient with 4 patches on different parts of the body. No wonder it wasn't working. Okay, because the patient already developed major tolerance. So my nitro won't work anymore. Okay, he's had it 2 days at least, because that was 4 different nurses, right? No, 4 days actually. Yes.
So it's constantly infusing, like while it's there, it's not running.
No.
out?
I'm talking about the ointment first.
Yes, so, okay, so while it's there, it's constantly going.
Absorbed, right.
Okay, so when they take it off and replace it, like start from scratch.
Right.
Okay.
Meaning there's a 12-hour nitro-free period when
okay.
we're talking about topicals.
Oh,
Okay, meaning the patient has it for 12 hours, but
Okay.
you should give them a 12-hour nitroglycerin-free period to prevent tolerance.
okay,
Only for the topical, okay? That doesn't apply to the oral, because of
Okay.
course, if you take anything orally, then that means half of it is destroyed by the liver, first pass effects. So it doesn't apply, the tolerance doesn't apply for oral,
Yeah.
only for the topical forms.
So they're-
Do we understand each other?
Yeah.
All right. The IV is for acute coronary syndromes. So this is only applied to your patient next week. Carl Shapiro is having an acute coronary syndrome. So therefore, do we keep giving him the nitroglycerin spray or a tablet? No, that doesn't make any sense, because you'll have to be doing that every 5 minutes, right? So therefore, he is ordered IV or continuous infusion of nitroglycerin.
Only for what?
Acute coronary syndromes. So we'll talk about that. That's the next topic. Keep in mind here for sublingual nitro, where do you put it?
Under the tongue.
Can they swallow it?
No.
It will not work if swallowed. The drug is designed for sublingual absorption. So the blood vessels in your mouth. Now, because think about it, when there is chest pain, so there's sympathetic stimulation, correct?
Mhm.
What will happen to the moisture of the mouth when you have vasoconstriction? There's dryness, right? So will the tablet dissolve in a dry mouth?
No.
So what can you administer if you observe dry mouth when you put a sublingual tablet? How much water?
Just like.
5 ml is acceptable, a teaspoon. Okay, put teaspoon, but tell the patient this is not to swallow the tablet. Okay, this is just to moisten the mouth. Okay, so to moisten the mouth, that way it's dissolved, because 5 minutes later, if the mouth is dry, you put a tablet there, 5 minutes later, it's still there. Okay, the tablet is still whole. Right. No, that won't work. Water, just administer, sorry, rinse the mouth. Again, just to moisten the mouth. I mean, a teaspoon is almost nothing. Okay? Just to moisten the mouth to facilitate absorption. Now, a few times, a few other details here on nitro. Now, nitro sublingual tablet or spray is supposed to generate a tingling or burning sensation under the tongue. That means the tablet is potent. Okay, that's a natural reaction. If there is none, usually maybe the tablet is expired or was damaged by sunlight. By damaged by sunlight, that means these tablets are in a brown glass container. Do not take them out. Some patients, old people like to take things out and use a pill organizer. Okay, tell them do not do that. The bottle is so small anyway. It's so tiny that doesn't, it fits in a pill bottle actually. So tell them not to take it out of the brown glass container. Keep it in there. If you really want a pill bottle, put the whole glass vial in there. No, put the whole glass bottle in your pill organizer. So this is, I already mentioned this, so there should be a 12-hour nitrate-free period. Okay. And for the, because it's very common now, so we have Roman, we have HIMSS, right, delivering ED medications by mail. So take note, ask the patient first, okay, are they taking any ED medications? So it could be sildenafil, which is Viagra, or it could be Cialis, okay? Yeah, before you administer nitro, right?
All the medications that cause the dry mouth.
No, you mean anticholinergics? Yeah. So here are your medications, table 23-2. Now, the beta blocker here is only for angina, okay? We do not use beta blockers in acute coronary syndromes. I repeat, beta blockers, this is under angina. We're still under angina, okay? We can administer beta blockers. This will help decrease the oxygen demand, okay? But this is angina, okay? Angina pectoris. So we have nitroglycerin, we have calcium channel blockers here. So all of them dilate blood vessels. Okay, so these first three groups all decrease preload. Afterload. Okay, so they affect arteries, so they all dilate arteries in three different ways. Then antiplatelets, why are antiplatelets included here for CAD? Why are coronary artery disease patients given aspirin? Okay, these are antiplatelets, okay? Please don't call these drugs anticoagulants. They're different, clearly here. Antiplatelets, aspirin, clopidogrel, prasugrel, ticagrelor. Anticoagulants are these, okay? Heparin or low molecular weight heparin. They're different. Antiplatelets affect only what? Aggregation. Only platelet aggregation. Does not affect bleeding time at all. Anticoagulants, however, yes, they increase or prolong bleeding time. Okay? They act in two different ways.
So you said the first three, they decrease preload or afterload?
Afterload, meaning they cause vasodilation. So next week, Carl Shapiro, of course, is hospitalized for acute coronary syndrome, so he will require a continuous infusion of nitroglycerin. And here's the rationale again for your beta blockers. And side effects. Okay, let's discuss self-administration of nitroglycerin. So the patient takes this at the first sign of chest pain, or they can also preemptively take it before engaging in activity that will increase oxygen demand. I already mentioned about the mouth being moist, which is crucial for absorption. Carry it everywhere. Do not take it out of its original container. What's the container again?
Brown.
Dark glass bottles, usually brown. So keep away from heat. They should be replaced every 6 months. They only last 6 months. I know we don't like to throw drugs away, right? Especially the elderly. It's a waste. I never got to use it. The bottle was brand new. Never even got to open it. Never had chest pain. It's a waste. Well, how do you respond to that?
The medication is only viable for that time period.
And what do you also say? You've been fortunate, right? Yeah,
Thank God.
it's actually good that you never had to use it. Okay. But when you do need it, it's important that it works. Okay, so emphasize that they only last 6 months, or like actually there's always an extension, right? But do you want to take a risk for something like this? All right, so tell them no, they're not expensive anyway. Okay, they're cheap, covered by insurance. Throw them away.
We'll replace it.
Okay, again, you can take it at the first sign of chest pain. Of course, do you continue the activity?
No.
Okay, you have to stop. Okay, so let's say it's in the middle of intercourse. Okay, just explain to your partner. Okay, we have to, we'll resume later, but we'll have to stop. Okay, I'm having chest pain. Okay. All right, let me clarify this portion here. Okay, so that we don't get any confusion on the exam. Thank you for reading, Miss Jordan. Recommend that the patient note. Yes, please.
Okay. Recommend that the patient knows polymorph increase in so advise the patient that it increases after taking 3 sublingual tablets at 5-minute intervals, emergency medical support.
Okay, let me clarify this. I know the book says it clearly, right? So after taking 3. Okay. Now, how did I describe angina? Chest pain. Is there a precipitating event? Yes, it's always
Or-
preceded by an
Some-
activity or emotional event, right? Okay. And then the chest pain, and then it's relieved by
Supplement.
rest and nitroglycerin. Okay, very good. So let's say the patient took 1 nitroglycerin tablet. The chest pain did not go away after 5 minutes. Is it angina? It is not angina. So, do you wait
No, call it-
until the 3rd before calling
Oh, no.
EMS? Okay, so this is what I mean. Since we know angina responds to rest and nitroglycerin, all right? So, after 1 tablet, nothing happened after 5 minutes. Is it angina pectoris? Maybe it could be, but do you want to take the chance? No, I don't want to take chances. So I want to get the ball rolling. So let's say if the chest pain went away after the 3rd tablet, good. You just say when the EMS comes, my bad. Okay, my bad. False alarm. Okay, but I was afraid because I did not get relief after 5 minutes. All right. Right, so we already discussed, they stop the activity and rest or lie down, sit down or lie down, right? And these are the side effects again, flushing because of the vasodilation, headache, hypotension, and tachycardia. The tachycardia here is, of course, reflex because if you dilate arteries, then that drops blood pressure, then there will be reflex epinephrine release causing tachycardia. Okay, we already know calcium channel blockers. Again, the purpose of your antiplatelets, aspirin, and or most patients will be on dual antiplatelet therapy, DAP. So they'll be both on aspirin and clopidogrel. Yep.
What?
Better effect. If the patient has high risk for bleeding though, they'll just choose one or the other. Let's say the patient has peptic ulcer disease, then just one. You still remember HIT, right?
Yeah.
Okay. Okay, oxygen. Now there's a little controversy about giving oxygen even if the patient is not hypoxic. But since it's still in our textbook, do we give oxygen?
Mhm.
Yes, we give oxygen. All right, any question on angina? And here's your teaching, chart 23-5. All right, let's go to acute coronary syndromes now.
I have a question
Yes.
related to the clinical, the patient that we have. We also have a order for bed rest.
This way.
Have to put a, like, prevention of the blood class for covering bed rest or?
It's for the control of chest pain. Because as long as the patient has chest pain, is there ischemia?
Mhm.
Yes, there's myocardial ischemia. So we're trying to increase blood flow to the myocardium.
Okay.
Plus, don't worry. I mean, if you, yeah, we have them on bed rest. So you're thinking, oh, high risk for blood clots. No problem. We have heparin infusing.
Fine.
But it's not used.
Yeah, that's not the rationale for, meaning if your goal is prophylaxis, meaning to prevent blood clots, we're not using
Infused shots.
heparin infusion. Okay, so we're using, yeah, prophylactic dosing, 5,000 units of heparin. Why are these called acute coronary syndromes? So the three acute coronary syndromes are unstable angina, NSTEMI, or this stands for non-ST elevation myocardial infarction, and STEMI, which is ST elevation MI. Until we get two things done, these two things are cardiac enzymes and a 12-lead EKG, you cannot tell these three apart. So let's say Sakari, Solev, and Johnson all came to the ER. Sakari has unstable angina, Solev has NSTEMI, and Johnson has STEMI. When they come in to the ER, they look the same. Their chest pain is exactly the same severity, same pattern. We can't tell them apart. So until we get what two things again? Cardiac enzymes, which are your cardiac troponins, and a 12-lead ECG, their diagnosis will remain acute coronary syndrome. When we get the results, then we can definitively say, oh, Sakari has unstable angina, Solev has NSTEMI, Johnson has STEMI. Are we clear? All right. So that's what acute coronary syndrome means. Yes, sir. Well, that's part already, but remember, BNP is exclusively for heart failure, meaning, yes, it's possible that a heart attack patient can go into heart failure, but it doesn't really diagnose the acute coronary syndrome. So only two tests we will use to diagnose acute coronary syndrome. What are they? Cardiac enzymes and right, EKG. Now, I won't say troponin because cardiac enzymes are sets. So cardiac enzymes now include troponins, T and I. And there's also I'm talking about BNP. So yeah, there's troponin and there's troponin T, there's troponin I. Okay, and then some doctors still are old school. They still order CKMB.
Mhm.
Okay.
Yes.
So the difference between the three acute coronary syndromes really is the degree of myocardial ischemia, meaning how narrow is the coronary artery, okay, or how severe is the blockage. That's really what separates the three. And of course, the results on the EKG, 12-lead ECG. Here in unstable angina, there is reduced blood flow caused by clot. After, of course, a rupture of the endothelial section, then a clot forms. The artery, however, is not completely occluded. So therefore, is there infarction?
No.
Infarction is death
Mhm.
of the myocardial tissue. There's no death, but is there ischemia?
Mhm.
Yes. Right. But however, could it progress though?
Yeah.
Yes. So unstable angina can result from, of course, there has to be angina pectoris, correct?
Mhm.
Meaning angina pectoris is also called chronic stable angina, okay, as opposed to unstable angina. So let's say I have angina pectoris or chronic stable angina, and I did not comply with my medications. Okay, I kept smoking, I kept eating ice cream, eating out, and I don't take my medications. Okay, so can my atherosclerotic plaque progress
Yeah.
and become unstable angina? Yes. So in unstable angina, unlike angina pectoris or chronic stable angina, wherein how did the chest pain come on?
By activity.
There was a precipitating event, right? It was preceded by a physical or emotional event. In unstable angina, there is no precipitating event. There is nothing preceded the chest pain. Patient was just resting, watching TV, eating popcorn, and the chest pain came on. Okay, there was no provoking event. Okay, there was no trigger
Unstable angina.
in unstable angina. In MI, again, there's two types here. We have NSTEMI or STEMI. The difference between these two, in both of these MIs, there is MI. Okay, so there is myocardial tissue death here. They died. Okay, a portion of the heart, usually the ventricles, died. Okay, because of 100% occlusion of one or more arteries. So these are MIs. The difference between the two is really the thickness. Obviously, so let me illustrate. Oh, maybe I have. Okay, so illustrating here. So this is NSTEMI. This is STEMI. The difference between the two is the thickness of the involved myocardium. So in NSTEMI, that means, yes, this is an MI. One or more coronary arteries were blocked, causing myocardial tissue death. This one died. However, it stopped. The infarction stopped, meaning was there restoration of blood flow?
Yeah.
Yes, the blood flow somehow got restored. So this is what we call a subendocardial infarction, which is manifested as NSTEMI, meaning yes, the patient had a heart attack a while ago. Okay, maybe at what time is it now? 2 o'clock. So they had a heart attack at 1:30. But then is there still obstruction now? Not anymore, right? So this is manifested by this EKG right here. So ECG reading will show ST depression as opposed to this one, which is ST elevation. So ST depression means, yes, there was 100% occlusion. But keyword there is, there was. Yeah, the patient suffered a heart attack. But is it still ongoing? Not anymore. Okay, so therefore, are we in a hurry to take this patient to the cath lab? No, meaning, does this have to be now? No, because it happened already, right? So yeah, this patient still needs to go to the cath lab, but not this moment. Okay, we don't need to call in the team like, hey, come here. Let's say this happens at 3 a.m. You don't have to call the team. You can wait till morning. Okay, because I mean, can you revive this? Can cardiac catheterization bring this back to life? No.
It's already dead.
This is dead. All right. So therefore, this is what NSTEMI looks like. And that is the ECG tracing. In STEMI, you have ST elevation right here, plus T wave inversion. Why does the T wave invert? What is the purpose of the T wave again? What is happening? They are repolarizing, right? Okay, so if they're dead, can they repolarize?
No.
No, that's why they appear inverted. Okay, and then there's ST elevation here because what is ST supposed to be?
When it's-
What's the normal appearance of an ST segment?
Isoelectric.
Supposed to be isoelectric, supposed to be flat, right? It's supposed to be flat right here. It's not flat. So here,
Mhm.
this is late because ST elevation represents early ventricular repolarization, right? So here, this is manifested by late because yes, some of these cells died. However, these are still alive. So while these will not contract and therefore not repolarize, these guys do. The ones underneath, the ones around it still repolarize. They still contract, they still function. So there will be early repolarization. Okay, so it's supposed to start early here, ST, but then it repolarized later because these guys died. So it will take time before these guys repolarize. So therefore, you will see the early repolarization will begin later. That's what the ST depression means. Here, there is early repolarization because there's no electrical activity in these guys now. There's zero because they're all dead. This is what we call transmural. So an ST elevation manifested by this is transmural, meaning the whole thickness of the myocardium was killed off. So therefore, will these still contract?
No.
No, this portion may contract, this portion may contract. These guys, there's no contraction here, right? And then we'll talk about the consequences after this. So since this is dead, so this heart over the next few days,
The whole thing is like that.
yeah, and months, no, they still have blood flow, but they'll have to
No,
compensate for the loss of this section. So now these guys will have to change shape
So that's why.
in
you rush to
response.
get them
Yeah,
done.
because this will become scar tissue.
Uh.
Okay, this is dead. So there'll be macrophages sent there. They'll eat up the dead tissue and then replace them with scar tissue. Again, scar tissue do not contract. So therefore, this heart will have to remodel. Okay, because if this patient survived this, then that heart has to compensate. Okay, it has to change shape because this is not contracting anymore.
So that's the reason why you rush to get them cardiac catheter.
Right, because otherwise it will kill even more. And this
Okay, I see.
patient will not survive.
The heart will compensate and keep up with.
Yeah, because the more this heart compensates without help, then the more oxygen demand, and then again it can't supply it because again the arteries are blocked.
So can it be like can this act like the stem is active? Like it's
Yes,
active now.
actively.
Can it resolve itself like the end stemming and stop? Or it's already a greater volume?
So it's all temporary.
So the damage
Not for a
to this one
STEMI.
is so much bigger, which is why it's ongoing.
Yeah, because if you wait, the patient will die. Yeah, this one, it happened already, but for a short period. Yeah, it killed off a few, but not anymore. Somehow the clot, the body somehow got rid of it. Okay, in NSTEMI.
So when the doctor's like, oh, like afterwards, a patient comes in for something probably unrelated. Since you had a heart attack, it's chances are it was an end stemming that they had
Yeah, so if it's NSTEMI, yeah, definitely they will need. If stable enough, then they'll be taken to the cath lab, but not right now. Okay. Of course, if the cath lab's available right now, okay, let's do it right now. But most of the time, no, there's somebody else in there. So these guys aren't really priority. Okay. Yes.
This one.
STEMI is an emergency. Yeah, it's a medical emergency.
Is this why we get the pericarditis?
Okay, so we bring in, there were 4 causes of pericarditis we mentioned last semester, correct? One of them is an MI. Because these died, so what will happen to surrounding tissue, including the pericardium, when something is dead there?
It's going to.
Inflammation, yeah, so there's inflammation of the connective tissue, so it causes pericarditis.
Does the NSTEMI also have risk of pericarditis?
Not known to, because it's not even touching the pericardium. Okay, so it's not likely to cause a pericarditis. So only a STEMI.
STEMI, I don't know if you've run into it, but the clinical manifestation for STEMI will be,
Same, the 3. Remember, unstable angina, NSTEMI, STEMI, they all look alike. Symptom-wise, same exact thing. The only difference is in the
Lab work.
cardiac enzymes and the 12-lead ECG. That's the only way you can tell them apart.
like tachycardia, all of those.
Same exact manifestations. Okay, so in MI, whether it's NSTEMI or STEMI, there is ischemia and necrosis of the myocardium. Okay, it killed the muscles in the myocardium. Did it kill it slowly or suddenly? Sudden, okay, sudden, abrupt occlusion, 100% occlusion of one or more arteries. So here's what happens over the next few hours. So the area of infarction develops over minutes to hours. Cells are deprived of oxygen, ischemia, and then injury, and then of course death or infarction, and necrosis follows. So thymus muscle applies to both stroke and heart attacks. So we need to get them to the cath lab as soon as possible. Okay. So 12-lead ECG identifies the type and location of the MI because there are 12 leads. So the doctor will see which lead shows the ST wave changes, and then they can identify which coronary artery is blocked. Of course, that will have to be confirmed with the cardiac cath. Once they go in, thread the catheter, inject the dye, then okay, it will confirm. Okay, it's consistent with the 12-lead ECG findings.
Didn't the ATP help with that?
We'll get to that when we get to, you mean TPA?
Yeah, okay.
Okay, so we'll get to that when we get to interventions or management. So manifestations, so just like any other patient who has decreased cardiac output, so on top of the chest pain, there will be shortness of breath. All of these again are signs and symptoms of sympathetic stimulation, right? So this is the cause of the symptoms is the sympathetic response.
So like, when you're triaging a patient like that, would you ask them about like when last you ate and stuff like that? Get a chest pain because they probably.
We don't bother because we're going to, right,
we-
we still need to get them to the cath lab anyway. So as I mentioned at the start, so the 3, unstable angina, NSTEMI, and STEMI cannot be distinguished, okay, unless we get what again?
EKG
And
and
enzymes.
cardiac.
All right, so let's talk about the enzymes. So here's the ECG. So I showed you on the whiteboard that there are ST wave changes. And there's also a pathologic or abnormal Q. The Q here will be sharp and really deep dip. So the Q wave is supposed to be only a few millimeters dip, right? So the the abnormal Q here will be very long and deep. Okay, so this is what I meant earlier. Remember when we talked about the nitroglycerin teaching? Okay, so look at it here. This is chart 23-6, assessing for acute coronary syndrome. Chest pain that is not relieved by rest or nitroglycerin. Did this statement say it has to be 3 nitroglycerins? Did it say it has to be 3 sprays or 3 tablets? No, it just said if it doesn't is not relieved by rest or nitro, is it angina?
No,
It is
it's no
now.
longer.
It could be, okay? Could still be angina, but do you want to take the risk? No, because this is the manifestation or characteristics of
Coronary.
acute coronary syndrome. So that's why if I were teaching a patient, when do they call 911?
Right away.
After 3?
After the first one.
After the first. But of course, after the first, they take it 5 minutes later, nothing. So they call 911, correct? So what do they do while waiting?
They're gonna-
Continue the second and the third. Are we clear? Yeah, of course, you continue that. And then you do the same in the hospital. Although in the hospital, yeah, we're already in the hospital anyway. So you can administer the nitro. It's already ordered for the patient. Of course, after the first nitro, no relief, 5 minutes later. So what do you do?
second.
Well, you do the same. Call RRT and then continue with the second and the third. Are we clear? All right. But it's, it's better if you're already inpatient because we have, ready access to a 12 lead ECG. We have, we have needles, we can draw troponin. Okay, so they're gonna draw up a troponin, so you go ahead and draw the blood, then doctor orders it. Here you go. You just give them the specimen bottle. Okay, so you save time. It's much better if this occurs in an inpatient. A different story if we're at home. And what was the number one cause of cardiogenic shock again?
MI.
Oh, an MI. So watch the patient with an MI for cardiogenic shock. So these are the manifestations already mentioned in the paragraph. Again, what's responsible for all these? Sympathetic stimulation. Okay. All right, let's talk about the enzymes. Okay, so here are the EKG changes. So you have the inverted T wave, ST elevation, and the abnormal Q. So see here, the Q is supposed to only dip here, right? This one is way too deep. So in unstable angina, if the cardiac enzymes come back normal, is it an MI? No. So the doctor will diagnose it's unstable angina, right? So we'll still treat you. No, we give you beta blockers, we give you calcium channel blockers, nitroglycerin, and beta blockers, right? For STEMI, of course, this is positive. Both STEMI and NSTEMI have positive troponins. You see here, elevated cardiac biomarkers. This one, the same. Okay. And then the difference really is in the ECG between these two. What will be seen here? ST elevation with or without T wave inversion. This one, ST depression. No ST elevation here. All right, labs. Now the troponin, the doctor can order C as well, but in my experience, it's usually T and I. The difference between troponin and CKMB, we don't have a graph here. So, okay, can you see this? Not very clear. Look at this one. Okay. Okay, so this is the timeline. So on the vertical axis here, you see the levels of troponin and CK-MB. And then here in the horizontal axis, these are days. Okay, this is not hours, these are days after the MI. Which one rises first? So blue is your, no, CK is green, troponin is red, and blue is myoglobin.
Okay.
Which one rose first?
Myo-
Myoglobin, followed by the CK and the troponin. Okay, so they are the first to rise. However, do they stay elevated?
No.
Troponin.
Myoglobin disappears after 24 hours, whereas CK also starts dropping, starting from within 24 hours, it starts dropping. But look at troponin. It stays elevated even up to how long?
Days.
Almost over a week. It stays elevated. So which one is more reliable? The troponin will be more reliable. Now, the significance here, of course, is the peak. So that's why when you see troponin orders and the patient has acute coronary syndrome, any of the acute coronary syndrome diagnoses, the troponin will be serial troponins. Okay, so they'll be taken every 6 to 8 hours or sometimes every 4. Now, the reason for this is we want to see what is the level, because the sooner we see a peak, that means what happened to the perfusion to the, okay, so we restored the perfusion. So when would be the soonest peak that you would like? 12 hours. Okay, so if it peaks in 12 hours, the patient has a high chance of recovery. If the peak is later, or let's say you have a double peak, you were on your way down. What's the significance of a peak? How do we recognize a peak? How do you know that was the peak?
We compared it to the baseline.
You remember COVID 2020? You remember the governor at that time, the Governor Cuomo had, gave you statistics on COVID levels. And then they were always looking for the peak. Yeah, so
what
why-
happens, like what activity?
No, I mean, why do you know that this number is the peak? How did you know that was the peak?
Based on the amount of.
Highest.
How do you know it was the highest
For a
number?
period of time, it was. the
Because what
highest,
was the next number?
Lower than
It was lower. Meaning, as long as it keeps going high, are we at peak?
No.
No.
So it takes
We
us
know
up.
it peaks because it started going down. Okay, so therefore, do we want to see a peak? Yes, we want to see, the sooner you see a peak, then the better the patient's outcome, right? So you see the significance why troponin is the most reliable.
Mhm.
Okay, and then one last thing is, so therefore don't expect troponin to be 0. Well, it's never going to be 0 because normal is like 0.012. Okay,
Yeah.
that's the normal troponin. So don't expect it to be less than 0.012 during the admission. Okay, it'll stay elevated up to a week or even after a week. Are we clear?
Uh-huh.
But does that mean if the troponin is still above normal, that the patient is still unstable? No, because the data that you want is the peak. Okay, so once we've peaked already and then it stays downtrending, we don't worry anymore. Yes, the troponin will stay elevated. You see that number. Okay, you see this graph. It will stay elevated, meaning those dead myocardial cells or tissues will continue to release troponin. Okay, so because they're released by injured or dead myocardial tissue. So that's why, remember in shock, I mentioned, will there be a rise in troponin in shock? Yes, but does that mean they have a heart attack? No. That means, did shock injure myocardial cells? Yes, because of the hypoperfusion, right? Because of the low blood flow to the myocardium, of course. there was injury to one or more myocardial cells. Okay, but that doesn't mean they were having a heart attack. This one though, not only is the troponin elevated, we have ECG evidence at the same time. And this troponin rise is really high. Okay, not like in shock wherein it's only 0.1 maybe, 0.2. Okay, nothing significant. All right.
So we wanna find, this, in this case, we wanna find, just wanna find the highest number.
Yeah, as long as it peaks and then starts downtrending, then the patient is more or less stable.
12 hours, if the number doesn't go down, it means. we have-
Yeah, so let's say it peaked already, right? But then while it was going down, you had another rise. So can you have a second peak?
Yeah.
Yes, you can have as many peaks as there is, because patient can have another heart attack. Is that possible?
Yeah.
Yes.
What level would you know that the patient basically,
We'll get to that when we get to the post management, okay, under cabbage.
So you, the normal person, your troponin is expected to be below the 0.
Yeah, below 0.012.
The normal individual.
So yes, technically CK is cardiac specific. However, is it reliable?
No, that is.
Not as reliable because again, it fades away pretty quickly. Okay, so it doesn't really give us here. Begins to rise within a few hours, but it peaks within 24 hours. Same thing with myoglobin. Rises quickly, but the thing with myoglobin is it's not really cardiac specific because this is found in skeletal muscles as well. So let's say we perform CPR on the patient, at some point, it will of course raise myoglobin, okay, because you're injuring a lot of chest muscles. So this is the treatment guideline in this particular order. So what do we need to do within 10 minutes of arrival?
EKG.
EKG followed by troponin. Okay, so this is done again within how long? 10 minutes of arrival. And this is the order. They get oxygen. So this author put ONMA instead of ONAM. Okay, well, Mona really is just to, it's easier to remember Mona, right? I mean, it's familiar, it's a name, Mona Lisa. But the order of administration really is either ONAM or ONMA. Okay, so it's interchangeable. Morphine and aspirin can be interchangeable, but oxygen, nitro are always the first two. Okay, so it's really ONAM or ONMA.
Wait, what? Onam?
Mona's-
Yeah, I'm not saying Onam.
Well, if you're looking for the order, it's ONMA or ONAM.
Onam.
So you see, you have your aspirin, Plavix, beta blocker, and statin. Okay, so it started right away. Now the statin, if you're having acute coronary syndrome diagnosis, it's going to be the maximum, which is 80 milligrams. Okay, the minimum is 10, maximum is 80. Later, when the patient's stable, yeah, the cardiologist may change it back to a lower dose. Okay. But during the acute period, we load them up with the maximum, okay, 80 milligrams. And look at this. So what's your major concern? Look at the amount of drugs we're giving. We're giving anticoagulants plus antiplatelets. Bleeding is your number one concern here. Okay, so this is a lot of antiplatelets and anticoagulants.
Yeah.
So our goal, of course, is to restore perfusion. So the current guidelines is we have up to 6 hours for NSTEMI, but for STEMI, it's about 60 to 90 minutes. Balloon ER to door to balloon time. But of course, hospitals are beating that time now, meaning they're advertising, lower numbers, like 30 minutes now. They're guaranteeing, come to Northwell Health. They will open that artery in 30 minutes, right? So where will you go? You get two hospitals here. One ad, this billboard says 30 minutes. This one says 60. Where will you go? All right. Okay, so they're trying to outdo, okay, because these are really big money making conditions, yeah, procedures, right? So these are cha-ching. Every time you go in there, chest pain, cha-ching, all right? A lot of money, especially when it involves open heart surgery now, right? So that's why they equip these things. Other money making admissions are maternity. Okay, so childbirth is very well reimbursed by yeah. So good reimbursements are maternity wards. So that's why hospitals invest. Okay, where have you given birth last? Was it some crappy hospital? It's very nice, right? Very nice, fresh paint all the time. Yeah, good. There's windows. Yeah, in the room
Oh,
you have
yes.
windows. Okay, yeah, it's beautiful. Okay, so because again, good reimbursement. So how much more if maternity is well funded? How much more these cardiothoracic
Even better.
departments? Yeah, so cardiothoracic surgeries. So that's heart and lung surgeries are very well funded. And if you work in those units, I encourage you to work in those because you'll have the best patient nurse to patient ratios. Okay, you'll never have to deal with. Of course, there's poop everywhere, right? Everywhere you go, there's poop. There's incontinence, but the ratio is very small. But they're very picky though. It's very competitive department. You go in there, you better, be prepared to compete with other nurses.
We don't choose people of color.
I wouldn't say that. I wouldn't say this is New York. Different down south. Down south, yeah. There's
Everyone
that.
on the floor in ICU is Asian or white, and the same for L&D.
I wouldn't say that. Well, in my hospital, we don't have that. It's classified. Okay, so let's talk about the gold standard of treating STEMI. It's PCI. So this is the gold standard. If there is a cath lab in the facility, this is the preferred intervention. Time again is 60 to 90 minutes. Okay, right here, 60 minutes or less. Again, most hospitals now have less than 60. Okay, they can do it in 30. If, let's say, you unfortunately decided to have a heart attack somewhere far from the nearest cath lab facility, so your only choice is a fibrinolytic agent, which is what Soler mentioned earlier, TPA. So we'll give you a thrombolytic drug instead. We'll discuss this later. So PCI is cardiac catheterization. Take note, cardiac catheterization involves the use of an IV dye. All right, so what's your number one concern? Okay, allergies to the dye. So if there are such patients, then doctors, of course, weigh the benefits versus risk. Okay, can they take that's one contraindication. So they'll weigh, okay, can they save the kidney or protect the kidney enough though? Okay, because we do have acetylcysteine, we have IV fluids, but that's not our concern. That's the doctor's decision. If again, the patient ended up in a non-cardiac cath capable facility, so you will be given thrombolytics. We'll talk more about thrombolytics under stroke because we hardly get MI patients who receive thrombolytics. And again, it's not the gold standard. Okay, this is only for a non-cardiac cath, and there's really not much here. I mean, you're not very far from a cath lab anywhere in New York City. Okay, so there's several. So we're talking here, maybe, you know, in the Midwest, let's say you're on Route 69. I mean, there's, you know, in the middle of nowhere, then all you get is thrombolytics. And since thrombolytics is the standard, your gold standard for stroke, then it's better off discussed in the stroke section. But the guideline for thrombolytics, though, is this. They should be given within 30 minutes from onset of symptoms. After that, it's too risky. Okay, the benefits are outweighed by the risk. If your symptoms started more than 30 minutes ago, then there's more complications compared to benefits.
Like, the stroke, people have a, what's it called, the bleeding type stroke.
Yeah, we'll talk about stroke another week. Okay, so since this is here and under stroke, I will test this again. So this will be tested twice, once in exam 1, second one on exam 2. So these are your indications. So definitely the patient has an MI, and less than 12 hours from the onset of pain. The 30 minutes here, let me clarify. This is if the patient has certain contraindications. All right. But of course, what is better, 30 minutes or 12 hours?
30 minutes.
All right. These are absolute contraindications. So if you have one or more of these, then thrombolytics is not an option for you. Only PCI. Only PCI. Now, this will apply also in stroke. Again, stroke patients, because most types of stroke is the ischemic type. The only treatment for that is TPA. So this is the same TPA they're using here, the same thrombolytic. So if the stroke patient has one or more of these, no TPA. No TPA for that stroke patient. Because TPAs are number one complication is bleeding or hemorrhage, then it would make sense that these are your interventions. So you prevent and watch for bleeding, because we can't really absolutely prevent bleeding. There will be some patients who will bleed, but the important thing is you catch it early. So prevention would be no unnecessary needle sticks anywhere. So don't stick anything up the rectum or avoid any lines if possible. No Foleys, no NG tubes, nothing like that. Nothing invasive. But of course, some patients will receive orders for, let's say the patient at the same time went into shock. Then do we need a Foley?
Yeah.
Of course. Let's put it this way, nothing unnecessary. Okay? No unnecessary invasive lines. And if the patient survives, then they'll be automatically candidates for cardiac rehab, either inpatient or outpatient. Most STEMIs are inpatient rehab. For NSTEMIs, they can do outpatient rehab. Some of them even get rehab at home. For activity, the guideline for activity is if the patient can climb two flights of stairs without symptoms, then they're okay to resume sexual activity. Okay, that's usually the guideline. If they can climb 2 flights of stairs without shortness of breath, then they can handle sexual activity. Yeah. Because that's a frequent question for patients. When can I resume? If not the patient, it's the partner. Okay?
I think male, right?
Male or female, same thing. So what do we discharge these patients on? So after, let's say they survive acute coronary syndrome, what are those drugs again? Yeah, antiplatelets,
Statin,
statins, beta
nitro-
blocker,
beta
okay,
blocker.
the nitroglycerin, and also calcium channel blockers. Oh, ACE inhibitors, don't forget ACE inhibitors. Okay, they're crucial.
You call them medications for heart failure, is that?
Yeah, so meaning when you're the one doing the discharge, make sure all those drugs are prescribed for the patient. If one or more is missing, call the doctor. Hey, you forgot the beta blocker, or you forgot the ACE inhibitor, right? Or the antiplatelet. Let's take a break. Come back at 3 o'clock.